Principles of antibiotic use and resistance. We have discussed during this microbiology, but the principles are often unchanged. They are similar, but there are some matters which include in the pharmacology. So hope this will be refreshing time you all for related to antibiotic use and its resistance related principles. First of all, you know who is Sir Alexander Fleming and relationship with the penicillin. It was invented, perhaps accidental invention, discovery related to this matter. As you know, this is this observation, but do you think at present can we do this? Because this is Staphylococcus aureus lawn and penicillin mani organism, if it is accidentally contamination, air contamination and growth occurs, but this zone often nowadays we can't see. Why it is? At present, MSSA is often resistant to penicillin due to production of beta lactamases. Now we can't do this observation. Think how antimicrobial resistance has evolved. That's how it goes, right? What is termed antibiotic? It is a chemical produced by an organism which kills or inhibits the growth of another microorganism. Antibiotics, but in broad term, antimicrobial chemicals that kills or inhibit the growth of microorganisms. It could be the natural, semi-synthetic or synthetic. Okay. So about the classes of antibiotics. This is beta-lactam antibiotics. You are familiar with this. Penicillins, cephalosporins, monobactams, carbapenems, and combinations. Penicillins, you know again, narrow spectrum and extended spectrum. Likewise, we can classify. Narrow spectrum, that is often penicillins. Also, beta-lactamase resistance like cloxacillin, flucloxacillin, dicloxacillin, things can improve. Once it is in this extended spectrum, they can again classify as aminopenicillin, carboxypenicillin, and uridopenicillins. Amino, more towards amoxicillin, ampicillin. Carboxy, it is ticagrelin. Uridopenicillin, piperacillin. About cephalosporins, first generation, second, up to fifth generation. So first generation, it is more towards spectrum is gram positive, while second, third, fourth, it's more towards gram negative. Monobactams, Astrionates, anti-staphylococcus, it's more towards gram negative. Carbapenem, it's a broad spectrum, positive, negative. But carbapenem won't kill MRSA. Keep this in mind. Okay, please don't use anti-MRSA antibiotics as carbapenems. Anti-staphylococcus aureus MSS is a possibility. Combinations, you know, with these beta-lactamase inhibitors like sulbactam, tazobactam, clavulanic acid, avibactam, wabobactam. So once we combine this with third generation cephalosporins, even fourth or with the carbapenems, we can get combinations. Right. So what is the spectrum of activity? I told in several locations. I know you know this. Spectrum means in which parts it can act. So in this spectrum, we consider prokaryotes and eukaryotes both. And within prokaryotes, can say gram-negative bacteria, gram-positive bacteria, mycobacteria, and atypicals like chlamydia, rickettsia. Eukaryotes, they are the infectious disease etiologies like fungi, protozoa, helminths, and different category, that is viruses. So there are antibiotics which may act mycobacteria, gram-negative bacteria. Would say it's a broad spectrum. But penicillin here, only gram-positive, it's a narrow spectrum. Here tetracycline, we put that gram-negative bacteria, gram-positives as well as atypical. So it's a broad spectrum. But neither antibiotic, which there's for killing prokaryotes, eukaryotes, both. Also no antibiotic to kill antiviral or virus or bacteria simultaneously. There are a few exceptions, but it's in clinical practice we don't use. There are no antibiotic is not effective against all microbes. Keep in that mind. So mechanisms of antimicrobial action. They go and act on cell wall. Cell wall protein, penicillin binding protein, penicillin PBS, they act on there, mainly cell wall inhibitors like beta-lactams, penicillins, cephalosporins, and other groups like bacitracin, vancomycin. So there are other, where cell membrane inhibitors like polymyxin B, then protein synthesis inhibitors like chloramphenicol, erythromycin, tetracyclines, streptomycins. And there are transcription and replication inhibitors, DNA synthesis, RNA synthesis inhibitors, quinolones, DNA gyrase, and topoisomerase 2 enzyme system leading to DNA replication inhibitor. And there are competitive inhibitors with metabolic activities. So like sulfonamides, trimethoprim. So it is, overview is there just to. This is about the penicillinase, where beta-lactam ring. This is termed the beta-lactam ring. With the presence of penicillinase, it destruct and convert into penicilloic acid. Now it is no activity towards penicillin binding protein, and they can't bind it and can't inhibit bacterial cell growth, cell wall synthesis, cephalosporin. So in the cephalosporin nucleus compared to beta-lactam, polypeptide antibiotics, vancomycin, bacitracin. Then there are mycolic acid in the Mycobacterium tuberculosis. Isoniazid ethambutol, which causes and acts on Mycobacterium tuberculosis, where it poses mycolic acid and interferes the synthesis of mycolic and assemble is inhibited. So protein synthesis, you know. Meanwhile, once protein synthesis, because bacterial or prokaryotes as well as eukaryotes, there are overlaps. So once enzyme system is, there are some overlap, they may tend to inhibit prokaryote or host protein synthesis as well. So ultimately it leads to toxic effects, adverse effects. Chloramphenicol may suppress bone marrow. Aminoglycoside due to nephrotoxic leads to nephrotoxic or ototoxic. Tetracyclines, which may act on GI tract and it affects the cell turnover. Then macrolides, it's often we use for gram positives. So polymyxin B, I said, gram negatives, and it's a last resort antibiotic for multi-drug resistant, extreme drug resistant gram negatives. It's highly nephrotoxic, but as well as therapeutic efficacy is high because we are out of stocks, like limited stock. Our armor is limited due to this emergence of multi-drug resistant pathogens like ESPL, if further carbapenemase producers. So with the presence of carbapenemase producers, we carbapenem like meropenem, imipenem, ertapenem, no action like. So then we have to go for novel like tigecycline or previously used like colistin or polymyxin. Colistin is a prodrug. Polymyxin is a direct active drug. About DNA synthesis, quinolones, fluoroquinolones, I said, then rifamycin like rifamycin for RNA synthesis, competitive inhibitors like broad spectrum. We have discussed this thing during microbiology, that's why I'm going fast. About the measuring antimicrobial sensitivity. As you know, once for the etiological diagnosis, once we have isolated the pathogen, we need Apart from their identity, we need antimicrobial susceptibility profile, ABST, to treat, to select the appropriate antibiotic, to target therapy. Empirically, we may start. We have already started, but streamline, going for targeting the things. We need ABST. MIC is much more important. But in nowadays, it's common practice we do to measure antimicrobial susceptibility, this diffusion. But it won't calculate MIC. To calculate MIC, we have to go microbot dilution or macrobot dilution or E-strip testing. About the antibiotic diffusion, you know, we apply a microbial loan there and put appropriate dish there and check following incubation. Next day we check is there a zone or not. And with the zone diameter, with the help of standard tables like CLSI table, UCAS table, we may say is it resistant or susceptible. Microbot dilution, it's a laborious technique, but it gives a good idea of proper value of MIC. Macrobot dilution also similar. We can calculate the MIC. Here E-strip, that is the novel application, versatile, but it's costly. But it's like ABST. Why just like this diffusion? Okay, but it's tried the MIC. That's you know, you are familiar with these things. I think we have done during the practicals as well as we have answered during those pieces as well. Okay, another concept. What is bactericidal and bacteriostatic? Cidal means it kills bacteria. While static means inhibit the growth of bacteria and keep it in a stationary phase. You know, initial lag phase associated with exponential log phase, then stationary phase. So here, these antibiotics, which are bacteriostatics, they won't kill those bacteria, but they keep bacteria in a static phase. They inhibit the growth of bacteria, rather killing them or destruction. But in real sense, no clear-cut categories exist as cidal or static bacteria. But anyway, that means cidal agents fails to kill all microbes. So if having high inoculum, imagine in infective endomyositis, in the vegetation, patient may have high inoculum, 10 to the power 8 per cubic millimeter. So it's a high inoculum. So those even well-known bactericidal antibiotics, they may be not able to kill all bacteria. Other way, bacteriostatic, they may kill the bacteria. So in the real sense, that's why I put this, but cidal and static idea in the principle should be there. But anyway, clinical outcome is the matter. So now we move further about the pharmacokinetics and dynamics. What is pharmacokinetics? That is what body does to drug. That is absorption, distribution, metabolism, and excretion. In the future lectures, we will discuss each group of a class of antibiotics and their pharmacokinetics and dynamics. Okay, here it is a principle. So PK, that is pharmacokinetics, that is body clearance. What is PD, pharmacodynamic? What drug does to body? In here, what it acts on the microbes, and their side effects also important. So in vivo MIC is directly related to therapeutic concentrations. But in real sense, while we knowing the MIC, it is not the best candidate to be the therapeutic concentration. That means MIC is important, but MIC itself won't say about the therapeutic concentration. What we want to know is about the therapeutic concentration. Other thing is about the MIC. MIC will guide us about the therapeutic concentration, but it is not the sole parameter. For that, there are pharmacokinetic, pharmacodynamic parameters. PK/PD relationship ultimately driven several parameters. So there are three. One is 24-hour area under the curve, MIC. Time over MIC. Cmax over MIC. These are the three main parameters. MIC is pharmacodynamic part. Area under the curve, time, Cmax, those things are distribution related. So it is pharmacokinetics. So here pharmacokinetics, pharmacodynamic association, relationship. Based on that, we have derived three parameters to guide the guide the therapeutic concentrations. So what is Cmax MIC? Cmax over MIC. It is applicable to aminoglycosides. You know amikacin, gentamicin, methylmycin, streptomycin, kanamycin, cafriomycin, like there are a lot of antibiotics. Commonly we use amikacin, gentamicin, methylmycin. So aminoglycosides. So it is the parameter which is applicable to this antibiotic group. That's why it's related to Cmax. So MIC is related to aminoglycoside. That depends on inherent characteristics. Okay. Based on that particular antibiotic character, class of antibiotic characteristic, this is the parameter where which represent its activity. So here, imagine, now we are going to inject weight-based formula. We'll say 6 milligram per kg daily dose. Gentamicin, we'll say it's a 50 kilo weight, body weight, 300 milligram we are giving as a bolus, parenteral. So once it is given, it takes time. Now first pass metabolism is evaded because we are given parenteral. So directly include into the peripheral and central vascular system, blood. So it takes time to reach the maximum. Concentration maximum, there is a time. Anyway, time is there. So once this has to be measured, but it's not done in everybody. Even therapeutic drug monitoring, we are not measuring the Cmax. We don't want ID. It has done in the research. It has previously done. Now we know, if we know the weight-based formula, what the dose given, we know gentamicin what is Cmax over MIC value. Our aim is to keep Cmax over MIC value in a particular value. It depends, but it's dynamic. MIC is, what is the MIC? MIC is that particular patient's isolate. Imagine we'll see E. coli, patient in a bloodstream infection following pyelonephritis, urosepsis. We have isolated patient is having E. coli, and we have calculated gentamicin MIC. We found that MIC is 2. So it is susceptible. So we are going to give aminoglycoside as a bolus single daily dose. So to kill, these are about bactericidal effects. To kill that particular E. coli, Cmax over MIC, there is a value, cutoff value. We'll say 100 for gentamicin. It should be more than 100. So for that, we are calculating the dose. It almost calculated 6 milligram per kg. That's how it goes. Okay. We don't want to do anything. We have to follow only the instructions. That is, we have to give weight-based formula. But the science behind this is, it depends on the MIC, because MIC is there, denominator. So Cmax varies with the weight and the volume of distribution. So we give fixed dose line, the weight-based dose, and with the MIC, there is a cutoff. That is our idea. But when we go for the other parameters, this is, we would say, concentration dependent. Concentration dependency. Again, this area under the curve MIC is another concept. It also concentration dependent. This Cmax MIC, 24-hour AUC and MIC, both are concentration dependent antibiotics. So their activities mainly depend upon blood serum concentration. That's what it's termed concentration dependent. So one additional point before describing this second parameter, usually advice is to give single daily dose of aminoglycosides. If we give multiple doses like 2 times per day, 3 times per day, it gives Cmax around, not this Cmax, because we are giving divided dose, 2 milligram per kg, 8 hours. So Cmax lies here. Then another 8 hours we give another. So Cmax is low. That's one point. Other thing is, repeatedly when we are giving this nephrotoxic drug, it probability or possibility of causing nephrotoxicity is high compared to giving single daily dose. That's the other advantage. Because if we give low Cmax, we won't be able to achieve our Cmax over MIC target. So that's why it's advisable to give daily dose. But there are exceptions, like when having patient with severe burn patient. Also, when we are combining gentamicin for the infective endocarditis, like Enterococcus, Streptococcus viridans, we give to achieve synergistic effect. We give divided doses. That's the exception. But our aim is to reduce the duration. Once reduce the duration of exposure, nephrotoxicity will be less. With high frequent doses, with the high duration of exposure. So our aim is give 7 days, like not 14 days, 21 days, it's strong. Nephrotoxicity is very high. We'll go for the 24-hour area under the curve MIC. I know it's a mathematics part. Again, area under the curve means this is the area where drug concentration goes. 0, we give, now it is injected. Now parenterally, serum concentration rises with the time. So time, the concentration. And there is a Cmax, that is the concentration maximum. Then due to metabolism excretion, it reduces the concentration. And there's a point, it becomes 0, that is C min. This particular area under the curve, this is the curve drawn for particular antibiotic. This is the MIC, where MIC is from the organism. Same milligram per liter or microgram per milliliter. MIC also comes as same units. So our aim is to keep above MIC, but here it's related to concentration maximum into MIC. We'll say concentration maximum is 200. Particularly MIC is 2. So MIC, Cmax over MIC is this for 100. So that is our aim to keep. Okay, that's what I say. But area under the curve, it's a different phenomena. We take all this particular value. We calculate using integration. Okay, mathematical technique, and we calculate this particular value and divided by MIC. And for that, there is another value. So usually area under the curve MIC is for fluoroquinolones like ciprofloxacin, levofloxacin, like again concentration dependent, and there are different cutoffs to achieve killing ability. There should be a value. Value should be above that particular cutoff. We'll say area under the curve MIC for fluoroquinolone is 400. That means this value should be achieved. It's varying with the MIC. Okay, that means area under the curve vary with the MIC. MIC is 4, so we have to do fairly high dose. Maybe we have to increase the frequency. It depends. Okay. Other concept is about time dependent killing. It is towards beta-lactamase and macrolides and cephalosporins. Here aim is, we know particular MIC, same thing. We'll say we are going to give penicillin for Streptococcus pyogenes bacteria. So penicillin should reach to blood in the bacteria blood, because Streptococcus pyogenes is in the blood. MIC is 0.5 milligram per liter. So we give penicillin dose, and dose usually given as heat hourly or 6 hourly. We'll say 8 hourly we are giving. Our aim should be dosing interval is 8 hour, MIC is 0.5. It should be more than 40 to 50% of dosing interval. That is 8 hour, we'll say 4 hours. Penicillin concentration in the blood should be more than 0.5, that is MIC, milligram per liter. You got the point. That is, dosing interval is 8 hour, MIC is 0.5. Our target should be, penicillin should be more than MIC, that is 0.5 over 50% of dosing interval. That is, dosing interval is 8 hour. Penicillin should be more than MIC over minimum of 3.5 hours to 4 hours should be there, 40 to 50%. To achieve static, bacteriostatic effect, to be bactericidal, penicillin, it should be more than 80% of dosing interval. Okay, that is maybe 6 hours, even more. Cephalosporins around 80 hours, 80% like again. So if we give ceftriaxone, we are giving daily dose. So MIC ceftriaxone may be differ, we'll say 0.25. So we have to keep at least to limit the growth. 12 hours, it should be more than MIC. To kill, it should be 20 hours. So even more, it should be more than MIC value. That's how it is calculated. So those parameters are very much interesting. There's another concept, post-antibiotic effect. It is persistent suppression of bacterial growth after a brief exposure of bacteria to an antibiotic, even in the absence of host defense mechanism. That is persistent suppression of bacterial growth, even brief exposure of bacteria to that particular antibiotic. So it depends on duration of exposure, antibiotic, bacterial species, culture media, and even class of antibiotic. So we think it is due to DNA function alteration, due to this kind of bacterial antibiotic activity. Or otherwise, think slow recovery after reversible non-lethal damage to cell structure. Following exposure, they go and reach into the bacteria and leads to reversible non-lethal damage to cell structure. So it takes time to revert back to recover. So it takes time. So we'll observe as a killing effect or station effect. Persistence of drug at the binding site. It would inhibit the growth. The need to synthesize new enzymes before growth can resume from the bacteria. So that's how we think. Usually most antimicrobials have effect on gram-positive foci, while for the gram-negatives, there are carbapenem cell protein and DNA synthase inhibitors like CPRO, inhibitors, protein synthase like aminoglycosides, chloramphenicol would act. So you can see, usually about the concentration-dependent antibiotics, they have post-antibiotic effect is prolonged, while time-dependent antibiotics, post-antibiotic effect is low, less, minimum. So again, based on the bactericidal pattern, type 1, type 2, type 3. Type 1, that is concentration dependent and persistent effect. So it poses both. So I said aminoglycoside, protein inhibitors, and DNA inhibitors. So PKPD indices is Cmax MIC for aminoglycoside, 24-hour area under the curve, OMIC is for chloroquine. Type 2 time dependence. Type 2 is time dependent, that is T over MIC. Type 3 type dependent and dose dependent. So macrolides and tetracyclines. Again, it takes, even though time dependent, we take 24-hour area under the curve MIC. 24 hours means that particular time period is area under the curve period is 24 hours. We take 24 hours. We'll say 24 hours. This area under the curve 24 hours. That's how it goes. So this is AUC24 MIC, that particular value. If that particular value more than 250 for ciprofloxacin, for E. coli, nosocomial pneumonia, eradication power is high. See how many days. Still, eradication is not achieved if this concentration is there. AUC and MIC less than 125. There are positive patients are high. That means positive means we'll say E. coli. For Cipro, E. coli positivity is high. That means eradication is not achieved. That's why we have to give fairly high and appropriate dose, and we have to keep this parameter for this particular patient's bacterial eradication with using ciprofloxacin. We have to keep AUC or MIC more than 250. That's how it's application. Right, another concept. Use of antimicrobials. Empiric, preemptive, prophylactic, and targeted. You know these things. Empiric. That is, in first case, once the patient presented to us, our main areas is infectious etiology or non-infectious. Once infectious etiology is suspected, what we have to do is we are going to give antibiotics while getting cultures for blood or appropriate focus of infection, and we do aspirations, and at the same time without delay we give antibiotics. That's the empiric therapy. So patient is having symptoms, but we don't know what is the exact etiology, but we think focus of infection and what is the probable organism, and we give that particular cover. Preemptive is different concept. That is antimicrobial in certain patients who are at high risk, like neutropenic sepsis, who are malignant patients, who are no symptoms there, but we think this patient is at a risk of developing aspergillosis, cytomegalovirus infection, invasive candidiasis. So we give voriconazole or ganciclovir based on that particular preemptive we give, and later on we do the specific diagnostics. Prophylactic is prevention, clear-cut prevention, primary prevention. That is, if you prevent the development of that particular microbe condition. Okay, surgical prophylaxis or subacute bacterial endocarditis prophylaxis, or patients with pregnant women with group B beta hemolytic or streptococcus agalactiae. So prevent next generation colonization, we give penicillins. Likewise, there are prophylactic. That is primary prevention. Targeted therapies, you know. So here again, prophylaxis, no infection, but prevention. Preemptive infection is there, but symptom has not appeared. So high level of guess kind of we give. But empiric patient comes with the symptoms, but we don't know what is the etiology. So once etiology is known, if it is bacterial or viral, if once AFS2, ABS2 antiviral susceptibility is known, we give. That is definitive. Suppressive is a part of definitive therapy, and we go further beyond. We give milioidosis, we give cryptococcosis, we give candidemia. This suppressive therapy is given, long-term therapy. Antimicrobial resistance. I won't do much about this. You know it's a familiar concept. Initiation of antimicrobial therapy. Bacterial count initially goes down, but antimicrobial resistant bacterial population subsequently emerge. So there are, in time, those initially killed bacteria, now they can stand against these antibiotics. So relative of complete lack of effect of antimicrobial agents are previously susceptible microbe. So MIC, what would happen? MIC will increase. Next, 3 to 4 days we do MIC, it will in time. If we do MIC, will increase. So about few concepts. That is, what is multi-drug? Drug resistance. We'll say multi-drug resistance. No susceptible. So not MDR, and there's MDR. MDR within MDR, that is again MDR we say resistant to 2 or more classes of antibiotics. Once it further it goes within MDR, XDR, extreme drug resistant, like TB. In TB example, isoniazid rifampicin resistant, also fluoroquinolone resistant, plus at least one injectable parenteral like amikacin, kanamycin or capromycin resistance. PDR is pan drug resistant, that's all resistance. Okay, there are E. coli like they are PDR. We are in trouble. Antimicrobial resistant mechanism, I will say, that is once we give the antibiotic will disrupt with the enzyme, that is beta lactamase. There are aminotransperases, acyl transferases, erythromycin, destructive enzymes. Likewise, there are a lot. Other thing is alteration of antimicrobial binding site. Penicillin binding alteration leads to cloxacillin resistant, methicillin resistant, ultimately MRSA emerges. Other thing is sporin loss and efflux pumps. Efflux means putting out, activation of efflux pump. Once they reach to the gram-negative cell membrane in cytosol, but with the presence of efflux pumps, they put them out. They can't kill, won't kill. Another thing is sporin, that is transmembrane transporters. Once transmembrane transporters are blocked, antibiotic won't reach. Can't kill particular microbe. This is about the resistant emergence. So what factors would promote? If we give the suboptimal level of antimicrobials, that's a low concentrations. Emergence is high. Other thing is, if bacteria having resistant genes, subsequent emergence will be there. So inappropriate use, prescription not taken correctly, antibiotics for viral infections were given, antibiotics sold without medical supervision, spread of resistant microbes in hospital due to lack of hygiene, all matters. Inappropriate, further, lack of quality control in manufacture or outdated antimicrobials, inadequate surveillance, defective susceptibility assays, poverty, then nowadays in pandemic, people prescribe all over. Use of antibiotics in food like animal feeds. They grow, enhance the growth, but at the time environmental contamination is high. So ultimately leads to burden, resistance, cost, and other important thing is our antibiotic armory will be in vain. So ultimately, we are back to pre-antibiotic era, right? So you can see unnecessary antibiotic prescription per year infections 30%. Here common cold, almost viral common cold, but we study suggests 100% unnecessary. Bronchiolitis 80%, sore throat 50%, sinusitis 50% antibiotics. They don't need antibiotic. So about multi-drug resistant TB, MRSA, you are familiar. Vancomycin resistant enteral, vancomycin used in the world. This is escape, bad bugs. New resistant patterns, ESBL, MC, CRE. So available antibiotic options. Then options available. You know these things. So what is your proposal to combat antimicrobial resistance? Just keep on looking. Just ignore it. No, strong. There's a concept called antimicrobial stewardship. Please look on this. Speed development of new antibiotics. It's like snail. Track resistant data national. It's happening slowly. Restrict antimicrobial use. It's another problem. Direct observed therapy like TB we can do. Proposal is use narrow spectrum as much as possible, but antimicrobial cocktails, that's mixtures, also they are like particular organisms only. How to select antibiotics is another important thing. Empiric use, focus of infection, idea should be there. Like clinical history examination with the other investigation, it will provide, is it pneumonia, is it Upper respiratory tract infection, is it ear infection, is it sinusitis, is it GI infection, urinary tract infection, central nerve system infection, skin and soft tissue infection, likewise. What could be the probable pathogen? How condition is severe? Based on that, you can select. Target therapy, once etiological diagnosis is there, you can go. Always go for narrow spectrum. Polyantibiotic use except TB like avoid. Proper dosage, weight-based formula. Omission means once start in antibiotic commencing, as well as omission is very much important. So here some antibiotic graph. If you read this, you get idea that will be important. So about the treatment efficacy, there are concepts. So we'll think host, that is human, pathogen, that is bug, and drug, and also environment. Okay, host parasite interaction we learned in microbiology. Then pathogen, other microbial interactions, you know that. So related to host, we have to think about host immunity. Is immunocompetent? Yes. Immunocompromised? We have to preemptive therapy as well as thinking about the probability of getting infection is high. So possibility of providing a preemptive therapy, we have to think. Comorbidities, if obese, it's another syndrome. Hospital ICU admission, hospital admission, HDU admission. Patient is in surgery, at a surgery who has undergone stress, high corticosteroids, so patient is more prone to develop infection, metabolism like metabolic disorder, sepsis, it's another entity. About the microbial biomass, what I said, virulence, speciation, antimicrobial susceptibility, likewise antimicrobial resistance, biofilms, they are the factors. About the drug, we'll say practice related. If we give on time, cure rate is high, recovery is high. Use of appropriate empiric choice, what I said repeatedly, yes. How to target later on. That's why we have to do the investigations as much as early before commencing antibiotic, but without delaying the antibiotic administration. Dose optimization. Based on renal function, liver function, we may have to alter the antibiotic dose. Practice related again, escalation. If patient is not responding, we have to go for high spectrum. De-escalation later on. If patient is responding, if patient is and isolate is susceptible, we can step down. Both term streamline it. IV to oral switch. Once patient is improving, we can give for IV, go for oral. Compartment drug, if patient is on proxycycline IV, we can give oral proxycycline. But if patient is in meropenem, now patient going to respond, we have to think what is the suited antibiotic based on that particular clinical case. Drug level monitoring, you have done seminar as well, then adverse effect monitoring, that also renal function, liver function monitoring. Key is the diagnosis, targeted therapy. Appropriate timing, we can wait. But if sepsis, bacterial meningitis, febrile neutropenia, patient is at a medical emergency, we can't wait, we have to give. But like in subacute bacterial endocarditis, vertebral osteomyelitis, discitis, we can wait. We can wait without prescribing antibiotic. We can go for take the sample, even blood cultures, even discitis blood cultures plus bone biopsy, bone graft for the histopathology and culture. Then once etiology is established, we can go for therapy. So taken together, first message is prescribe without antibiotic, without a delay. Administer without a delay. Even prescribe you give doctor, but nurse maybe not giving on time. So you have to monitor that. That's a very much important practical point. Once specimen have taken for culture, start it. Otherwise, we won't get positivity. Then you are blaming the lab. Yes, but we can't. How dare we found? If molecular diagnostic tests are readily available, we can do. Otherwise, it's a problem. Select appropriate empiric choice. Compare organ status, liver, renal. Then optimize. Weight-based formula is very much important. About the targeted therapy. Is it bolus, infusion? We'll later discuss about when we are discussing of penicillin and cephalosporins. I will show the importance of giving infusion on particular antibiotics once we know the MIs, not as empiric therapy. Monitor clinical response. That's a clinical application. Future of chemotherapeutic drugs, nanomolecules, antisense agents, there are a lot. And also there are extractions from different plant extracts for testing for MRS. It's there. Thank you.